Give me just a second. Let me get back to my PowerPoint. Okay. So as we all know, this is a presentation related to steps from screening to treatment with primary focus on mental health illnesses. I am Dr. Nivedita Nadkarni. I'm a child psychiatrist and I primarily work at Essentia Health. I'm a outpatient psychiatrist over there, and I have been working there since 2019, so almost 5 years now. I finished my training back in 2014, and that was in Virginia. And I moved to Fargo to start my first job, which was at Trey St. John's. It was an inpatient hospital, and I worked there for 4 years before starting outpatient. So I've kind of seen both sides of mental health, outpatient and inpatient. And I feel very passionate about kind of spreading education related to how to handle mental health situations, mental health diagnosis, treatment, and that's mainly what I'm trying to achieve with this presentation today. Should we go ahead and start, or are we waiting for more people to join in? What do you think? Start? Okay. So before we begin, let's go over the objectives that we want to focus on today. So the primary objective, like I already said, is to improve knowledge of assessment and evaluation of mental health disorders. I want people to feel comfortable evaluating a mental health patient, kind of trying to come up with a plan of how to proceed without kind of having any confusion about, kind of the right way to do it. So kind of like the protocol of what we do as mental health professionals in clinic. So increasing awareness of differential diagnosis of mental health conditions is also going to be discussed today. And then finally, to increase the understanding of the biopsychosocial factors, which are kind of involved in the assessment process, which help us formulate a case or treatment plan. So these are some statistics. Obviously, it's important to know why we are doing this, right? So based on statistics from 2016, there were 20% youth in the United States who were diagnosed with a mental health disorder, a behavioral or development, like the whole spectrum. And that's a big number. So that tells us how important it is to spread awareness and know or kind of screen for it, even on the primary root level, like, primary care clinics or even, at the social work level, so that these patients get the right treatment. Again, 2018 to 2019, there were 15% of adolescents who were diagnosed with major depressive disorder in the age group of 12 to 17. Again, a pretty high number. And 37% of these kids had feelings of sadness, hopelessness. 20% had seriously considered suicide. And again, given the high rate of suicide currently in the community, I feel like this is a striking number that everybody.
Everything was fine previous to starting, so
it's like maybe
she froze.
Froze up there. Let's see here.
Are you able to contact her directly, Jen?
As I'm talking muted, I am texting her.
Perfect. The joys of technology.
Oh, okay.
Oh,
There we go. And just as we're waiting, I did put the pretest in the chat. So you can take some time to do that while we're getting connected. It looks like she's off altogether now. Okay.
she's coming back in the room. There we go.
And you are muted. There we go.
Yes, I'm sorry about that. I don't know what happened here. Can you hear me, see me? What's happening?
We can hear and see you. If you want to share your PowerPoint
Yes,
again.
the share screen went
Yep.
away.
Thank you.
Do you know how long back we were already on the steps?
You were doing demographic data yet.
I don't know when I froze. I didn't even realize it.
Slide 3, I think, is where you were at.
Okay. Okay. So I'm gonna keep the window of you guys kind of on the side so I know when I disconnect. Okay. So I think we looked at the numbers and how striking it is and how high they are, which is why this topic becomes even more important to kind of be aware of. To start the screening of mental health patients, I feel like it's kind of divided up into the identification and evaluation. So the evaluation process, again, we are going to further divide up into kind of the interview, the differential diagnosis that come with it, medical comorbidities that can be associated with certain symptoms that are presenting as mental health symptoms. We're going to talk about symptom rating scales, mental status examination, which is one of my favorite topics because I feel like it's one of the most important tools I use in my practice and how easily it gets missed. And then finally kind of going down to the clinical formulation. So the biopsychosocial model and the 4 Ps, which again, we'll talk about once we get there. Assessment for safety and treatment planning. So let's begin with identification. Well, most clinics have different ways of screening for the most common mental health disorders, right? So depression, anxiety. I know there's no universal screening available currently for anxiety, but we often hear scales like the GAD, or, I think sometimes the initial nursing intakes are useful in picking up on those things. So identification is very important. It kind of gives you an idea going into the exam room, what might be the most important piece to focus on. The screening instruments are vital, especially I work with children, so mostly under 18. And so getting collateral information is a big part of what I do, whether it is daycare, parents obviously would be the primary source because most of these kids come with a guardian. Hearing them out, getting information from them is extremely important. School, which is like the second most important thing in a child's life, right? They spend 6 to 8 hours in school every day. So what the teachers observe, what the social workers there, the school counselors see, helps us know what's really going on. Because sometimes parents are not aware of things that the school counselor knows. So not ignoring that is extremely important. If the patient has a therapist, that can be a very important tool too, because often, especially in adolescents, they feel more comfortable talking to their therapist than they do with their parents. And so getting all of that information before making a plan can help you go in the right direction. And it makes it easier to not miss things, especially when we are talking about subtle things like, somebody was so much into cheer or dance, and then the last 3 months, they haven't even wanted to go. That is significant. So I feel like collateral information is very important. The people who referred these patients to you, obviously, it's hard in the real world to have the time to do all these things, but whenever the opportunity presents itself, ask them, so what exactly was your question? Or when you have recommendations, reach out and let them know that, okay, I saw your patient, this is what I feel. And if there was something that they wanted to know more than what you answered, this would be the best situation to do that. Then it comes to what is the patient here for, right? So the chief complaint, review of psychiatric symptoms, mental status examination. So all of this is kind of what we're going to talk about more as we move further, but that's where I would say the identification piece comes. Next, and the most important piece, obviously, is the evaluation. When a adolescent, for example, presents in your clinic, it is very important to know what is developmentally appropriate and what is something that needs to be addressed and treated. Like, for example, if a 15-year-old comes to the office and, mom's talking about how he's irritable, or, there's a lot of kind of bickering going on about rules and curfew, and there's slamming doors, and, you know, not, it's important to know what the baseline of this kid looked like. If the mom says that he was extremely, kind of like a team player and extremely respectful and polite, and this is like a sudden change from baseline, yes, it's significant. But if we see that gradual, kind of as the teenage years hit, it is pretty developmentally appropriate to want that autonomy, to want to be the boss of their own world. And that is not a pathology we need to treat. So it's important as they go through different stages to know, like, for example, if a 7-year-old patient is talking about not wanting to go to school because they are anxious, and, they don't want to kind of move away from their family, or their mom's dropping them off and the kids crying, that can be developmentally appropriate at some level. But if a 13-year-old is doing that, then we know that's significant. You can't just ignore that as a developmental stage. So just kind of briefly brushing over that, DSM-5, again, that's the Bible of psychiatry for us. I mean, that's what we are trained to know. And, there was a lot of shift between DSM-4, which is what was going on when I was training, and then now DSM-5, where there's new diagnosis, new criteria. So making yourself familiar with the DSM might be helpful, especially if you're dealing with a lot of kids with mental health issues. And just even if you have a chance to go through the main, or the most common diagnosis, like, ADHD or oppositional defiant disorder, major depressive disorder, I think it helps a lot in guiding your interview when you're seeing patients. Again, the DSM talks about, like, the time period, the symptoms, like, the differentiation between, say, psychosis associated with schizophrenia versus bipolar. All of that is important to have the knowledge of. A diagnostic interview is primarily the hallmark of what I do. I feel like the interview, talking to the patient, observing the patient, getting the history from the patient. It's pretty much my bread and butter. So I feel like that is extremely important in a psychiatric evaluation. Again, there's different factors to it. So the first point being the most important, you need to be familiar in the language that is being spoken. The patient and you both need to communicate effectively, because otherwise it becomes a challenge for them to tell you what they need and for you to understand. So make sure that piece is not missed. And this is especially important if you're dealing with refugee population or people who are not from the country, just to make sure that they know everything that is being said, even if it means having an interpreter involved, or, these fancy gadgets that they use at our clinic where, it just kind of finds an interpreter and they just translate stuff. It becomes harder, obviously, because you want to connect with the patient, but it helps the flow of things much more. Especially, I mean, the common situation I come through is the child is pretty fluent in English, but the mom or the dad are not. And that's a piece you can't miss, right? So the interpreters have a big impact on that interview. It's important to observe the patient when you're talking or when the diagnostic interview is going on. And what I mean by that is the body language, which is what we're going to talk about in mental status examination. But the direct observation is as important as the information that's been spoken. Because, say, there's a particular topic that the patient just shuts down on or doesn't want to talk too much about, you should make a mental note right there that, okay, maybe I need to bring this up later once he's more comfortable with me. And like we already discussed, collateral information, very, very important. It's typically tricky to start a new patient encounter by just seeing the patient alone, for me anyway. So what I sometimes do is I get the patient and the parent in together. The first 10 minutes or 15 minutes, I try to get a sense of what they feel is the most important thing that needs to be addressed. And then when the patient is a little more comfortable, less anxious, obviously, in a clinic in this kind of very medical setting, I ask them if it's comfortable, if it's okay with them, if I talk to them alone and then the parent can wait outside for a few minutes. And most of the times they are happy with that model instead of me just taking the patient in alone right from the get-go, because then they are confused. Sometimes they don't even know why they're there. Like when I ask them, do you know what's going on? Or they're like, nope, I just came here because mom told me I need to come. So I feel like that helps, but try to get some time alone with the patient, especially if it's a 13 and over kind of population, just because they don't always share everything with parents, and it's important to give them that safe space where they can say things that they don't want to say in front of the parent. And what I mean by that is it could be simple stuff. I mean, obviously the big stuff like substance use and stuff, but suicidal thoughts. A lot of adolescents don't want to talk about it just because they don't want their parents to, either stress out or even, kind of get burdened by that. So be mindful of that. That helps a lot. Now, I feel like everybody does HPIs, right? History of presenting illness. I mean, whether it's a medical model or the psychiatric world, I feel like that's where we start. So the goal when you're doing your presenting illness or getting the history for that is to, in your mind, come up with a diagnosis. And what I mean by that is you should have a sense of what is it that I'm dealing with. So the initial interview should focus on what has been going on over the last few months, or what distresses the patient the most. Now, the typical or the commonest symptoms that come to the clinic, especially in the pediatric world, are ADHD, depression, and anxiety. So there could be different reasons that present or these symptoms are due to different reasons, and these could be medical reasons as well, right? And in this table that you see is focusing a little bit on the common diagnosis that can be associated with some of the mental health symptoms that we see. And again, the commonest one in clinic that I think most of us have encountered would be thyroid dysfunction. I mean, hypothyroidism can look like depression. Hyperthyroidism obviously, has increased anxiety. And so it's easy to miss those things if you are not already aware or looking for it. The other ones, I mean, it's a big list, so I don't want to focus too much on it, but I know any autoimmune disease or epilepsy, especially temporal lobe epilepsy, can present in a very psychiatric kind of way. And it's important to know that this can be more. Again, the reason we talk about it is because if you're not aware of it, you're going to miss it more frequently. So if you know, this will help, especially patients who come from the ER. It's so much easier to get blood work, imaging, all of that done in the emergency room, so that you're already aware of what you have when you're doing a psychiatric evaluation. Certain medications can also cause symptoms of anxiety, depression, and ADHD. We all know that opioid drugs or analgesics, people are frequently on painkillers. And again, not so much in the pediatric world, but adults who are on multiple medications, they can all have features of anxiety, depression, and it's important to be mindful of that, which is why anytime a new patient presents, you need to have their most current medication list. What are you taking over the last 2 weeks? And sometimes we don't confirm it, and that is, I would imagine, a big mistake, because I've had patients who show up with like 10 medications on their list. And then when I sit down and talk to them, they'll be like, oh yeah, I'm not taking A, B, and C, but then I've been taking D 3 times a day instead of once a day because, for so-and-so reason. So those things can never be clarified unless you ask the patient directly. So it's important to kind of review the documentation, but also confirm it with the patient. Or if you have resources, then, the nurse can do that beforehand, before you start your interview. Benzo withdrawals, again, a big one in the adult psychiatry world, can also present with anxiety. The patient is jittery and, looks like they're having a panic attack sometimes when actually they're withdrawing from medications. So those would be important considerations here. I'm going to make sure I'm not running out of time. Okay. All right. Substance use, again, another big piece that gets missed. if you're not looking for it. And the commonest substance we know, again, caffeine, right? Most of us are addicted to caffeine, and when that gets excessive, or if younger children especially are drinking Monsters, or I don't even know the names of some of the new energy drinks that are in the market, but they do present like they have ADHD. They can't sit still. They're all over the office, and just on a visual observation, you're going to be like, okay, this kid has ADHD. But then you go into the history and the kid's like, oh yeah, I drink Monster every morning. It helps me wake up. And then you're like, maybe not so much, right? So be careful not to miss little things like that. And again, in a typical psychiatric interview, it's easy, especially if the child is all over the place and it's come in the way of you being able to talk to the parent. It's easy to miss, like, what do you eat every day, or what are some of the energy drinks you have. So it's important to make a note that rule out everything else that could be causing this before saying that, okay, this looks like ADHD. As for anxiety and depression, again, alcohol can have that like the depression related kind of picture, especially if the patient is not disclosing it. It's hard to kind of miss that. So blood tests always help. Mental health conditions that overlap are also important to be aware of. So if a patient is presenting with irritability, for example, there can be many different reasons that can cause irritability. If the patient has severe anxiety, they can be irritable. If they are depressed or bipolar, a lot of the times presents as mood dysregulation and irritability. So it's important to kind of be aware of the different mental health conditions that can cause similar symptoms. And this table will help you kind of go over some of those and the various overlaps that you can see. I do want to get to my cases, so I'm going to go ahead and try to go on the mental science examination piece more quickly. Psychiatric disorders very commonly can co-occur, which means a single patient can have more than one diagnosis, right? In clinic, the commonest cases I see, especially in children, are kids who have depression and anxiety, or ADHD and anxiety. And it's important to go in trying to look for everything that they are kind of presenting with. Like, I would give an example, which will maybe make this a little bit easier to understand. So if, say, you have a 14-year-old who presents with severe anxiety, not wanting to go to school, having severe social anxiety when they're in a crowded environment in school, and that is what they are telling you is the main reason they're seeing you to get help for that. In your head, you're thinking, okay, this is social anxiety or anxiety disorder. But then towards the second half of the interview, they also say, oh, well, I was diagnosed with ADHD when I was in kindergarten, and I used to take medication for it, but now I don't. That's when you're like, okay, history of ADHD. But what do I treat at this point? Do I treat the ADHD or the anxiety? Well, I think everybody knows it's the anxiety, right? What the patient is most upset about is what you treat. Once the patient stabilizes and the anxiety is under control, it is a good idea to, during follow-up visits, look at the ADHD and assess, whether it was a legit diagnosis, if there's psychological testing that was done, and then treat it. But I would treat the most concerning symptom first, or which is causing most distress. This will also help build rapport, because the patient will trust you, and the likelihood of them following up is pretty high if they form a relationship with you. Medical conditions that need to be looked at. Again, we talked about this a little bit. It's a good idea to get basic labs when you see somebody for the first time. So thyroid function tests, comprehensive metabolic panel, sometimes fatigue can be associated with low hemoglobin levels, so a hemogram. I also like to get vitamin B12 and D levels just to rule out deficiency. So make sure all of those lab tests are done. But again, that's most of the people in the medical world are aware of this. Symptom rating scales. I know there was a previous lecture that was done on this, so I don't want to go into too much detail of this, but this can give you a very good heads up going into see a patient, like when you review the chart and they have already answered some, standardized symptom rating scales like PHQ-9 or G87, you know that this patient is probably presenting with, either it's a high PHQ-9 or a high G87 or even ADHD rating scales that the parents are bringing in. That gives you a good guideline of where to start the interview, because there's so much to cover, right? It always helps to be more focused in the beginning and then kind of spread out as you go. Now comes the most important part again. Make sure you guys let me know when I'm running over time, but I'm just gonna focus more on the mental status examination. So I don't know if this is something that might be helpful just for psychiatry or maybe all over the medical spectrum, but this is like your hidden tool where the patient kind of says what he wants to say without using words. So starting with like basic stuff, if we are talking about a patient who has presented to your clinic in shaggy clothes, hasn't, he's smelling or hasn't even bothered to brush his hair or brush his teeth, that itself should raise a flag in your head, right? I mean, obviously, it can be their normal presentation in maybe, I don't know, 5% cases, but typically patients take care of their grooming when they're going to see a doctor. So if somebody is not paying attention to that, that should be a red flag right there. And you should keep that in your formulation. Like, okay, patient does not really care about grooming. So what does that make you feel? Has the patient had low motivation? Has the patient not been taking care of their daily activities? And that should, again, click that, okay, maybe I should keep depression as one of my differential diagnosis. Motor activity, again, in ADHD kids, we all know they are unable to sit still. They're typically all over your office. Anybody who's assessed a patient who has ADHD, especially the hyperactive type, will know that they are, they don't follow the boundaries. They're trying to touch everything. They're not letting you talk to their parents. So again, that comes in motor activity. Kind of moving more towards depression and bipolar, I do want to say that this particular aspect is very important. Patients who come with mania will typically seem very agitated. And again, what I mean by agitated is not aggressive, but just kind of their mannerisms or the way they are, or, just like a threatening posture. All of those things are significant. Or on the other side, somebody who's extremely depressed will barely be moving in their chair. And so that's significant. You need to see that, okay, the psychomotor retardation is significant. And I'm going to make a note of this when I make that diagnostic formulation in my head. Speech, there's a variety of things you can see in speech. Either they barely want to talk to you, or they, again, going back to appearance and speech together, they're not looking at you, they're not talking to you. Again, not always something that you would expect, right? Especially if it's an adolescent. In a younger kid who's scared to be in the doctor's office, this can be developmentally appropriate, where they just don't want to be there, and that's acceptable. But when you see an adolescent do that, you need to be mindful of it. You definitely ask them how their mood has been over the last few weeks, because that is part of what we want to not miss. Most kids have a hard time telling you that they have been feeling depressed, but their mannerisms or their affect, like tearfulness, right? A lot of children will say a lot just when they are talking about the last few weeks, or like, for example, I think this is one of the cases I discuss ahead, but if there's been a loss, when they're talking about the loss, you can see their whole body language change, and that is significant and should not be missed. When it comes to thought processes and thought content, oh, you know what? I forgot to mention one more thing in the speech. It's important to look at the volume when it comes to mania and bipolar. So pressured speech, where, is a big kind of sign of mania, which is associated with bipolar. And they also tend to be very hyperverbal. Again, same example, a bipolar patient with thought processes is going to have flight of ideas, meaning they will go from one topic to another topic to another topic, not necessarily with any connections. And the conversation or the diagnostic interview is going to seem very scattered, because you ask them a direct question and you're going to get a very roundabout answer, sometimes not even answering that question. So again, this is like a telltale sign. It helps you understand what you're dealing with here. Thought content focuses more on, hallucinations, delusions, suicidal thoughts, aggressive thoughts, wanting to hurt someone else. So important to kind of ask those things when you're seeing the patient. Perceptual disturbances, again, the same stuff. Delusional thoughts or hallucinations can be in your face, where the patient is literally responding to internal stimuli, or it could also present itself as they're shut down and it's almost like they're hearing voices while they're talking to you. So it's important to not miss that. Like if they're not answering your question and they seem distracted by something that's not obvious, I would definitely make sure I ask them, are you hearing voices, or have you been, scared of voices in your head? And that gives them that outlet to start talking about it. Again, cognition is your one-on-one interview will help you understand where their cognitive status is. If we are dealing with a patient who has dementia, again, this part would be very important because you don't want to miss memory loss or short-term memory. Just if they can't tell you what they did the whole day before they came to see you, that has to be something that you kind of make a mental note of and go back to. Abstract thinking. Again, in children, this is hard to kind of assess, but in adults, it is something that helps you get an overall sense of, you ask simple questions related to what do you do all day, or what do you do after work to relax? And, this is where some of these concepts can be evaluated. Insight and judgment are very complicated kind of concepts, but the best way to simplify it, I would say, is if the patient is telling you what is happening and they are motivated to get help and they have a good understanding of what's concerning to them or what's wrong, I would lean towards good insight. But if the patient is in denial, the mom and the teachers are telling you that things are wrong, things need to get better, and the patient is denying it all for whatever reason, I think that's where I'm questionable about whether this patient has good insight. Judgment, again, depends on, their presentation, their impulse control, how they've been able to handle themselves in real life, whether they are, driving their car too fast, or have they been attending school every day? Do they want you to help them, or are they blocking any any chance you're giving them? All of that comes in the judgment. Most adolescents and children I deal with, it's hard to kind of say for sure that they have good judgment, but I have seen a few who are very responsible and, almost function like adults. So I would say they have good judgment right there. For example, these are the commonest things. So what we talked about right now, this is more of like a typical mental status examination would look like. In a patient with depression, like I mentioned, most of the times they don't care about their grooming. I mean, they're so preoccupied with their depression that is not even a priority. So important to not miss that. Poor eye contact can also be seen in children who have social anxiety, or even adults. They don't want to look at you. They're kind of staring at the floor and trying to avoid eye contact. A big one in autism, especially if we are evaluating someone who was brought in by their parents and, is a questionable autism. If they're not looking at you, won't say a word, those are important things to kind of note. Again, psychomotor retardation is very common in a depressed patient. Sometimes depressed patients can also present as very angry and irritable, but then when you talk to them more, it all comes down to that underlying depression that's bringing on the frustration. They tend to have a lot of feelings of guilt, low self-esteem, self-blame. And again, these are not things that are easy to kind of disclose to somebody unless you trust them, right? So that initial trust building, trying to establish some kind of a relationship before you go down to asking some of these personal kind of topics is extremely important. I mean, if you ask a patient within the first 5 minutes of their presentation, if they're having suicidal thoughts, chances are they're going to be resistant. But if you establish a relationship for the first 10, 15 minutes and get them to trust you and show them that, you know, you are here to help them, they will share much more. And in the long run, this would be a much effective patient doctor relationship. Going to anxiety again, you know, go through different, or we can look, I mean, the presentation can be very different. Some of these patients can have very good insight. And so they will come and tell you that, you know, I feel tense, my muscles are tight, and I feel like my heart races. But when you look at them, some of these things are visible. Their hands are trembling, or they're sweating, or they're moving a lot in their chair just because this is so uncomfortable. This is all picked up on mental status examination. And again, in a primary care office, things are fast moving. So it's hard to miss these things if you are not focusing on them specifically. And that's why I think it's important to discuss here. Going to the biopsycho social model. So I feel like this is like a compilation of everything that you use to formulate your case, right? So going back to the biological factors. So what am I talking about with biological factors? This includes their family history, any trauma history, any medical issues. So everything that was happening biologically that could have resulted in the current situation. Psychological obviously is more, you know, your cognitive schemas, or, you know, how you process information. So this is more related to your feelings and your behaviors and unconscious conflicts. Social events are equally important. Any big changes in life, any breakups, any you know, traumatic life events, these compile the social aspect. The 4 Ps of clinical formulation: the predisposing factors, the precipitating factors, the perpetuating and protective, again, pretty self-explanatory. But predisposing is mainly the biological that we talked about. So family history. If a patient has 3 generations of, you know, relatives who have had bipolar disorder, in your head, that should be a red flag. Okay, this person is at a high risk. Or there's a history of completed suicide in the family. Very, very important to ask that question, one, and to keep that in mind. Precipitating factors are, again, you know, things that happened before your symptoms started, or, you know, kind of around that time. And a lot of the times this could be any big loss, any big change, breakups. Important, again, it's not necessarily the reason they are having these symptoms, but something that worsened the clinical picture. Perpetuating factors are ongoing symptoms while the patient is struggling with these issues. And the protective factors, again, this is what helps the recovery process, right? So what are the strengths? What kind of a support they have? How motivated they are? How resilient they are? And so this model together is going to help us come up with a clinical formulation. Okay. Safety planning, I'm not sure if this was already discussed in another lecture, but again, this is a big part of what we do, right? If the patient has suicidal thoughts, again, most of the screening tests should flag it. So you should be aware of it even before the patient walks in. But if not, it is very important to ask the patient. Again, not one of those questions you ask right away. As you go along and the patient trusts you more, he can tell you if he's having suicidal thoughts and how serious they are. A lot of the times I feel like patients who have a strong family support are in a much kind of the odds of them being able to stay safe are higher. But again, you have to be able to identify the high risk patients and triage them accordingly. You cannot miss trauma. So you have to ask the patient, do you feel safe living where you're living, or is there anything going on right now that makes you feel unsafe? And especially important in children, and that little window when we talked about you are with them alone and the guardian or the parent is not in the room, is probably a good time to ask that too. Because if you're asking this question in front of the parent, chances are the kid's gonna lie to you or try to avoid the question. So make sure you don't miss those really important things, because this is your window, right? This is the time you get with your patient. Once the patient walks out the door, it's very hard to kind of get anything directly from them. So suicidal thoughts, safety, like just feeling safe in their environment, extremely important. And, you know, make sure that you determine the appropriate level of care in terms of their risk for harm to self, to others, and, you know, whether they'll be able to follow up with you or whether they have supervision. And some of those different issues. Let's see. Are we on time, Jen?
Have,
Or do we need
it's
to wrap up soon?
12:42. You have about 15, 17 minutes left.
Okay, all right. Now, treatment planning is, again, a big summary of what we have already talked about. You have to look at the effective treatment interventions you can place when you see them. After you have made a diagnosis in your head of whether this is major depression or anxiety or ADHD, you start thinking about, okay, how do I treat it? So you have to prioritize what's most important, right? So like we said, if depression is the presenting symptom and seems to be the most important, you need to see how severe it is, what level of distress it's causing. So the quality of life of the patient, how is that getting compromised because of this illness? That helps you determine what kind of treatment needs to be in place. Like, for example, if a patient is presenting to you first, like even before they've seen a therapist or the school counselor, and they seem to have anxiety, the most important factor that has not been addressed before they came to you was getting therapy started. So kind of making sure the guardian or the patient know that they need to get established with a therapist while you are working on the medication or, kind of other levels of care is extremely important. You always ask the patient what do they want. So just because they came to see the medication provider does not mean that they want to be put on a medicine. I cannot tell you how many times I've seen patients who come to me and, obviously their primary care provider has sent them to me to consider medications to help them. And the patients in the end are just like, we are worried about side effects and we don't really want to be on medications, but can we know more about them? So that conversation is important to have. And if you don't ask them that and end up telling them that, okay, I'm going to recommend an antidepressant, they're going to be more kind of reluctant to tell you that, well, I don't really want meds. So make sure you ask them, what do you want? What can I do to help you? Or what do you think you're looking for? That kind of opens up that dialogue where they can tell you that, well, I'm worried about side effects, but I'm open to doing therapy. And then you can go into that because cognitive behavioral therapy is a very effective modality for treatment of anxiety and depression. And so, maybe that's what we try. And if we keep that relationship going, they will come back to you in a few months if they didn't feel like therapy gave them what they wanted. And so this patient doesn't get missed then, as against, someone who was interested in therapy, but got the impression that you only wanted to do meds. They're probably not going to want to come back. Informed consent, again, if you're starting a medication, the patient needs to know what they're getting into. As we all know, there's a black box warning with antidepressant medications, antipsychotic medications. So it's important for parents, especially if it's a child patient, to know, and adult patients as well, that there is a black box warning associated with antidepressants. And if they have any of these concerns, they need to get in touch with you right away instead of, kind of waiting for the next appointment. A lot of the times patients feel that, if I'm going to see this doctor again in 6 weeks, I can't really reach out. So it helps them to know that, no, I want to know if something is wrong once you start taking this medicine I'm prescribing you. So talk about what you diagnosed with them. They want, a lot of parents will be very proactive about this, but if it's an adult patient you're dealing with, it's not a question I would imagine gets asked a lot that, what is my diagnosis, doctor? They don't want to know that. They just want to get treatment and get out of the office, right? So it's important to tell them that, based on what we've talked, it seems like you have major depressive disorder and this is what we treat it with. And these are our options. And what do you think makes most sense to you? So let them know what their diagnoses are, or even if you have like a few others that you're thinking about or want to order psychological testing for, this is a good time to discuss with them that, I hear your concerns about focus and concentration issues. Maybe we should look at psychological testing to rule out ADHD. That's a very helpful kind of input that you can give the patient because they feel heard and they know that, okay, you're keeping all their concerns on the radar. You also want to talk about risk benefits of different medications so they can choose wisely. If a patient has a very active lifestyle and has to be kind of at school in the morning and has a job after, you cannot use a medication that's going to be sedating. So these are things the patient should know so that they can choose wisely. Again, documentation extremely important in our field, especially. So if you have talked about things, make sure you write it in your note so that, everybody is clear. The patient, a lot of the times, can also access their own notes. So I have a few patients who go home and just look at the notes about, oh, what did we talk about again? I don't remember everything. And so it's helpful. And again, it also legally saves you in case, the outcomes don't end up in your favor. So make sure everything is documented, including risks, benefits. One more piece that, on the previous slide that I forgot to talk about was it helps to give patients some kind of resources in terms of side effects from medications, or, who to contact, or, the various kind of resources available in the community that can help them in terms of case management, therapy. So don't forget to kind of give them that information if you already have it. In my clinic, it helps to have, some printed information available anyway about the resources. And, whenever relevant, the patient is just given the handout and they can go home with it. Last but not the least, I do want to talk about a few cases. Again, these are the common cases I see in my clinic. And so I felt like this makes it more relevant for people about, how to go about it. So this would be, again, an 11-year-old female who comes to your clinic with symptoms of anxiety, nervousness about school. She and mom, they're telling you that she has nausea every morning, stomach pains, sometimes vomiting, and just refuses to go to school. This has been going on for 4 months, and they've already missed 18 days of school, again, leading up to her grades declining. When you talk to mom, she tells you that her classmates have been bullying her. And so, again, about being her short. So this is kind of the initial presentation. Does this seem relevant? I mean, again, participation would be helpful if you had any specific questions. So this is kind of the time when I would kind of be able to talk one-on-one. Does anybody have like any questions about this case or a similar kind of situation that they have come up with?
So you can feel free to unmute yourself. You can turn your cameras on and we can have conversation for these last 10 minutes to go through case assessments, questions and answers.
Okay, well, I can take it from here. So in this case, I would say the first thing you want to do is try and find out what this child's baseline was, right? Like the last 4 months have been difficult, but what was the baseline? And if the mom shares with you that this kid was happy to go to school before this and used to excel in school, was also involved in cheer or dance, and there's like a sudden change, that is significant. And especially the nausea, vomiting, or stomach pains, that would indicate psychosomatic symptoms, right? So if the patient has had a medical workup which has been negative, I would lean more towards anxiety in this child and want to kind of investigate more, either by talking to her teacher or, going over some of the things that have changed at home. And parents are an excellent source for that. I know a lot of the times the pressure on the first intake interview, I mean, this is more maybe self-driven, but a lot of clinicians want to diagnose and treat in the first intake appointment itself. And I do want to say that that is not important. Like it is not a time crunch there. The right treatment is what's a priority, right? So even if it takes you 2 or 3 visits to get to the right diagnosis and treatment, that is completely fine, because that is what the patient needs, instead of a rushed diagnosis and treatment, just to kind of get something started. So in this case, I feel like trying to get to know what the baseline was, talking to the teacher or a therapist would be helpful. This patient particularly, it doesn't seem like has seen a therapist. So that would be our first recommendation is, right? Like it's an 11-year-old patient. That is a first-line treatment when it comes to anxiety in children. So establishing with a therapist was probably the first thing I told them to do while getting collateral information, and then considering a medication if symptoms just don't improve as they go along is a good kind of idea. Anybody had any questions about this case before we move on to the next one? Okay. The second one is your typical 16-year-old kid with depression. So this is kind of how I would say my commonest depressed patient would present as. They come with depression, low motivation, difficulty focusing in school, which leads to declining grades, poor sleep. They have started therapy, but have not seen any change with it. He also reports passive death wishes. I wish I could just sleep and not wake up, or I wish I wasn't alive. Hopelessness, again, over the last 1 week, and the PHQ-9 is elevated. I'm hoping people are resonating with this, like this has happened, in your own clinical practice. But again, very important to rule out any medical issues, right? If this patient has seen you for the very first time and does not have any primary care provider who has seen him or investigated medically, definitely I want to get like a thyroid function test, a CMP, and make sure he is medically stable. And only then you can look at some of these symptoms which have lasted for 4 weeks. Again, we're going towards that DSM criteria for major depressive disorder, especially with the suicidal ideation. That makes it, again, you have to safety plan with them. Make sure that parent is aware of the suicidal thoughts in case of, trying to make sure they take them to the appropriate level of care if things worsen between this time and the next time you see them. I would imagine cognitive behavioral therapy with medications is what I would, in my head, try for this patient. I know cognitive behavioral therapy by itself can also be helpful, but in adolescents especially, the combination has given us the best results. So that is always my go-to when it comes to a patient with depression. Good idea to find out about other symptoms too. A lot of times anxiety and depression go hand in hand, like we talked about. So make sure you rule out all of the other symptoms. I know, I was just wondering when so this case, again, I'm getting ahead of myself. So this case is also a patient who comes to you with mood issues, just like the previous one. Also with insomnia, like the previous one, but the presentation varies because this patient has not slept for 4 nights, or he comes to you after 1 week of psychiatric hospitalization. So you already know this is not like this significantly impaired their functioning, right? Insomnia for 4 nights, bizarre behaviors reported by peers, racing thoughts, delusional thoughts, saying that they can levitate through meditation, make music that would get them awards, hallucinations, voices telling him that God wants them to heal the world with his music. The mental status examination, again, very classic. They're elated, they're talkative, they're difficult to interrupt, but redirectable. And then mom also shares that they used to smoke marijuana a few times over the last year. And when they were in the hospital, they started an antipsychotic medication, but they couldn't refill it after discharge and now are having trouble sleeping again. So what is that is that ringing a bell? Anybody want to take a guess? We talked about it a little bit. Bipolar, right? So this is kind of a classic presentation for someone who presents with mania, most likely their first episode, because otherwise, the parents are kind of already looking for signs, but a very first episode of bipolar mania can present this way and ends up in a psychiatric hospital just because, it's so sudden onset and the acuity is so high, especially with, the delusional thoughts and hallucinations. A lot of patients do a lot of at-risk behaviors when they are manic and haven't slept for days together. This actually was a patient of mine, and that's why I thought I'll share it. But, he came to me and then we restarted the risperidone and he did great. So it is very effectively treated if the patient comes to you at the right time and the intervention is made before things get too far. And so he's actually doing great. I mean, I know it's just side information, but just following up with your provider regularly, doing the blood tests you need to do. I mean, just a side note, because he's on risperidone, we watch for his lipid panel and comprehensive metabolic panel every 6 months, and I feel like he's done really well on that medication. So that's your classic bipolar case. ADHD, again, most primary care providers have seen this in their clinic. You know, a 12-year-old with ADHD. Oh, wait, this was the anxiety one. But a patient who was stable on ADHD on Concerta or methylphenidate now is coming with low mood, decreased interest in activities, poor sleep, crying spells, anxiety. When you build a relationship, they share that they had to put down their dog recently, and patient is very tearful. So again, that mental status examination, right? When she's talking about the dog, her whole body language is just like completely tearful and she's shut off. They don't have therapy. So again, I would start with the bare minimum, right? Like this child just had a big loss. I mean, a dog is like a sibling for a lot of these children. So starting therapy is the first thing that should come to mind. Then you look at options like medication. Is this an adjustment disorder, or is this an actual major depressive disorder? And again, as you see them over time, you can make that call. And then last but not the least, your classic ADHD patient, right? Energizer bunny, like presentation. Mom and dad are worried about struggling in school, fidgety, won't sit still, gets overexcited when unstructured, bouncing off the walls from the minute he wakes up and has big emotions. They have meltdowns at night every day, so they don't know how to help him and they come to you first. Again, if you're the first person this kid is seeing, you have to advocate for psychological testing, get information from teachers, make sure those ADHD Vanderbilt scales are available, and all of that will help you decide if this patient has ADHD and then treat it accordingly. Now, I know we are running out of time, but we do have 1 or 2 minutes left. So I want to open it up for any questions or anything that seems relevant.